So good morning, friends. I'm going to talk about trachoma. Trachoma was previously known as Egyptian ophthalmia. The word trachoma is derived from the Greek word for rough, which describes the surface appearance of the conjunctiva in chronic trachoma. So because the conjunctiva appears rough because of the formation of the follicles, this conjunctival surface becomes rough, and that is how the name was given. It is a chronic keratoconjunctivitis, primarily affecting the superficial epithelium of conjunctiva and the cornea simultaneously. So it is basically involving the epithelium of conjunctiva and the cornea. Later on, the other tissue are also involved. It is characterized by a mixed follicular and papillary response of the conjunctiva. The tissue, venous formation, and the late stages cicatrization giving the rough appearance. So not only follicles, but there is a papillary response also. In conjunctiva, in other tissues, there is cicatrization, there is venous formation. So all these things contribute to the rough appearance, and that is how the name trachoma has been derived. Etiology of the trachoma: if you look at the causative organism, the trachoma is caused by Chlamydia trachomatis. The organism is epitheliotropic and produces intracytoplasmic inclusion bodies that are known as HP or Halberstadt Provazek bodies. So HP bodies is the abbreviation that we use for the Halberstadt Provazek bodies. Predisposing factors: the age. The infection is usually contracted during infancy and early childhood. Otherwise, there is no age bar. There is a female preponderance. No race is immune to trachoma, but the disease is very common in Jews and comparatively less common amongst Negroes. Climate: it is more common in the areas with dry and dusty weather. Socio-economic status: the disease is more common in the poorer classes on account of the unhygienic living conditions, overcrowding, unsanitary conditions, abundant population, paucity of water, lack of materials like separate towels and handkerchiefs, and the lack of education and understanding about the spread of the contagious diseases. All these socio-economic factors contribute to the spread of the disease. There are environmental factors like exposure to the dust, smoke, irritants, sunlight, etc. They increase the risk of contracting the disease further. As far as source of infection, the main source of infection is the conjunctival discharge of the affected person. Therefore, superimposed other bacterial infections help in transmission of the disease by increasing the conjunctival secretion. Obviously, if there is a secondary bacterial infection, there is more likelihood of the increase in the conjunctival secretions, and that is what is going to be the cause of the dissemination or spread. So that is about the source of infection. As far as the mode of infection, it can occur via direct spread. It may occur through contact by the airborne or the waterborne modes. Vector transmission of the trachoma is common through the flies. Material transfer: it plays an important role in the spread of trachoma. Material transfer can occur through the contaminated fingers of the doctors, nurses, and contaminated thermometers. It is therefore of the paramount importance that the medical staff, doctors, nurses, and the attendants must maintain the very high standards of the hygiene. And when we use the tonometers or similar other tools for the diagnosis, they must be well sterilized before use. So this is of paramount importance. Then other sources of the material transfer of the infection are use of the common towel, handkerchief, bedding, and the surma rods. So these are some of the practices that are still prevalent in the rural India and that may contribute to the spread of the infection from one person to another. We call them fomites. The fomites means the articles that are used by the patient and they are shared by the other subjects or other members of the family. Now, what are the clinical and pathological features of trachoma? It can be divided to different phases. The first phase, the phase of the active trachoma. In active trachoma, it usually occurs during childhood due to active chlamydial infection. The incubation period of the active trachoma varies from 1 week to 2 weeks, that is 7 to 14 days. Onset of disease is usually insidious. However, it can present in the acute form also. Now, in this stage, in the absence of the secondary bacterial infection, a pure trachoma is characterized by these symptoms. There can be a mild foreign body sensation, occasional lacrimation, slight stickiness of the lids, and scanty mucoid discharge. But if there is a secondary bacterial infection, then typical symptoms of the acute mucopurulent conjunctivitis that develop on top of the symptoms that I described just above. There are signs that we look for in the conjunctiva. You can get congestion of the upper tarsal and the pharyngeal conjunctiva. You can get conjunctival follicles. The follicles look like boiled sago grains and are commonly seen on upper tarsal conjunctiva and the pharynx, but may also be present in the lower pharynx, like a semilunaris and caruncle. Sometimes the follicles may be seen on the bulbar conjunctiva, which is pathognomonic of trachoma. In other conditions, you do not see follicles in the bulbar conjunctiva. That is quite uncommon, but that is pathognomonic of trachoma. Then there can occur papillary hyperplasia. These papillae are reddish. They are flat-topped raised areas which gives red and velvety appearance to the tarsal. Pathologically, each papilla consists of central core of numerous dilated blood vessels, which is surrounded by lymphocytes and covered by the hypertrophic epithelium. So if you look at the histological structure of the papillae, you will find that there is a central core of the blood vessels surrounded by lymphocytes, surrounded by a hypertrophic epithelium from inside to the outside. Now, if you look for the corneal signs, you may find number one, superficial keratitis, which may be present in the upper part. You may get Herbert's follicles or Herbert's spits. It refers to the typical follicles that are present in the limbal area. Histologically, they are similar to the conjunctival follicles. 3, you may get progressive penis. We are talking of the stage of the active inflammation. So, in the active stage, you will get progressive penis. There is infiltration of the cornea associated with vascularization, which is seen in the upper part. Typically, it is the upper part of the cornea which will, or limbus, which will show the progressive penis. That means the vessels are superficial and they lie between epithelium and the Bowman's membrane. Later on, the Bowman's membrane is also described, leading to some degree of the opacification of the cornea. Penis in acute trachoma is progressive, in which infiltration of the cornea is ahead of the vascularization. So, the progressive penis is characterized by infiltration ahead. So, if you see infiltration beyond vessels, that means you are dealing with active trachoma and a progressive penis. Corneal ulcer may sometimes develop at the advancing age of the penis. Such ulcers are usually shallow, which may become chronic and indolent. A trachomatous corneal ulcer is usually seen at the advancing age of the penis, typically, and they are shallow, oval ulcers that are usually indolent. The second phase is the phase of cicatricial trachoma. The cicatricial phase of the trachoma manifests in middle age. It results due to the continued mild grade chronic inflammation. So if the inflammation drags on after the acute attack or acute stage. If it drags on, then it will lead to a phase of the cicatrization. In the chronic immune response, it is the chronic immune response consisting of the cell-mediated delayed hypersensitivity. We call it type 4, as I described in my earlier lectures. So it is a delayed hypersensitivity type 4 response to the intermittent presence of the chlamydial antigens. Essentially, the immunological response to the intermittent presence of the chlamydial antigens. Now here, what you get. In conjunctiva, there are certain congenital signs. One, conjunctival scarring, which may be irregular, star-shaped, or linear. The linear scars present in the sulcus subtarsalis is also known as the Hart's line. The second one is the concretion. There are hard-looking whitish deposits varying from pinpoint to about 2 millimeters in size. These are not calcareous deposits, but are formed due to the accumulation of the dead epithelial cells and inspissated mucus in the depressions called the glands of Henle. So if I'm asked, define what is concretion, it is the collection of the inspissated mucus in the glands of Henle. Simple. There are other conjunctival manifestations. There are actually sequelae, which includes concretions, pseudocysts, cirrhosis, and symphylae. So all these manifestations can be seen in the conjunctiva as conjunctival signs. Second is the corneal signs. The corneal signs include regressive penis, which is also known as penis siccus, or penis siccus, in which the vessels extend a short distance beyond the area of the infiltration. Means it is a kind of a defense mechanism on the part of the body to extend the vessels beyond the infiltration, and that is called the regressive penis. It shows that the immune system of the body has taken over to combat the situation. The second is the Herbert splits. The Herberts are the oval, circular, pitted scars left after healing of the Herbert's follicles in the limbal area. So basically, these are the Herbert's follicles, which gets converted into Herbert splits because of the scarring. The corneal opacities may be present in the upper part. It may even extend down and involve the pupillary area. It is the end result of the trachomatous corneal lesion. The other corneal sequelae may be seen. It includes corneal ectasia, corneal xerosis, and total corneal penis, which is a blinding sequelae. There are certain signs present in the lids also. The sequelae of the lids, sequelae in the lids may be trichiasis, entropion, tylosis, which is thickening of the lid margin, ptosis, medrosis, and ankyloblaphron. So these are the sequelae that are seen in the lids. Lacrimal apparatus may also show some changes. Sequelae may be in the form of chronic dacryocystitis and chronic dacryoadenitis. So this is how the tissues around the conjunctiva cornea may get affected because of the trachoma. Now, for the grading of the trachoma, Macmillan's classification is often used besides the WHO classification. The Macmillan's classification identifies different stages. Stage 1 is the incipient trachoma or stage of the infiltration. It is characterized by the hyperemia of the palpebral conjunctiva and immature follicles. So stage 1 is very difficult to identify many times clinically. Stage 2 is the established trachoma or stage of the florid infiltration. It is characterized by appearance of the mature follicles, papillae, and progressive corneal penis. So that stage is very easy to identify. Stage 3 is the stage of cicatrization. Cicatrizing trachoma or the stage of scarring, that is what we call it. It includes obvious scarring of the palpebral. Stage 4 is the healed trachoma or stage of the sequelae. The disease is now quiet and cured, but sequelae due to cicatrization may be present, and that gives rise to symptoms. Now, this is the WHO classification I was talking about. TF is a trachomatous infiltration follicular. Now, it is a stage of the active trachoma with predominantly follicular inflammation. To diagnose this stage, at least 5 or more follicles, each measuring 0.5 millimeter or more in the diameter, must be present in the upper tarsal canal. So that is TF or trachomatous infiltration follicular stage. TI, there is trachomatous inflammation intense. I stands for the intense. This stage is diagnosed when pronounced inflammatory thickening of the upper tarsal canal obscures more than half of the normal deep tarsal vessels, which it indicates an intense inflammation. TS or trachomatous scarring. This stage is diagnosed by the presence of scarring in the tarsal canal. These scars are easily visible in white bands or sheets. There is fibrosis in the tarsal canal. TT or trachomatous trichiasis. TT is labeled when at least one eyelash rubs the eyeball. The evidence of the recent removal of interned eyelashes should also be graded as trachomatous trichiasis. Trachomatous trichiasis, to call it TT, there should be at least one eyelash which rubs against the eyeball, especially the cornea. CO means corneal opacity. This stage is labeled when easily visible corneal opacity is present over the pupil. Corneal opacity present over the pupil is important. This sign refers to the corneal scarring that is so dense that at least part of the pupillary margin is blurred when seen through the opacity. The definition is intended to detect corneal opacity that causes significant visual impairment, less than 6/12. Complications. The only complication of trachoma is the corneal ulcer, which may occur due to rubbing of the corneal tissues or trichiasis when superimposed bacterial infection occurs. So the only important thing to remember and to bear in mind is the corneal ulcer, which can be seen in many of these cases. Now, to diagnose, first let's talk about the clinical diagnosis. The clinical diagnosis of trachoma is made from its typical signs. The clinical grading of each case should be done as per the WHO classification into TF, TI, TS, TT, or CO, which is as I described earlier. As far as the laboratory diagnosis, the conjunctival cytology should be done. We do a gym-size stain sphere, which shows predominantly polymorph-nuclear reactions with presence of the plasma cells and the Leber cells. This is suggestive of the trachoma. So plasma cells and the Leber cells must clinch the diagnosis. The second is the detection of the intrusion bodies. In conjunctival smear may be possible by gym-size stain, hydrogen stain, or immunofluorescence staining, especially in cases of the active trachoma. We can go for detection of the HP intrusion bodies. Then ELISA, the enzyme-linked immunosorbent assay for the chlamydial antigens, can also be performed. The PCR, the polymerase chain reaction, can also be done for making the diagnosis. Isolation of chlamydia is possible by yolk sac inoculation method and tissue culture technique. Standard single passage McFly cell culture requires at least 3 days. So that is how the chlamydia can be isolated. Serotyping of the trick agent is done by detecting specific antibodies using microimmunofluorescence. We call it micro-JF method. Direct monoclonal fluorescent antibody microscopy of the conjunctiva smear is a rapid and inexpensive method, so that can also be employed. Management of a case of trachoma. First, let's look into what is the treatment of active trachoma. The topical therapy regimes are best for the individual cases and consist of tetracycline 1% or erythromycin 1% eye ointment twice a day for 6 weeks, or sulfacetamide for 20% sulfacetamide eye drops thrice a day with 1% tetracycline ointment at bedtime. This again for 6 weeks. So this is the best treatment regime for the acute cases of drug. Systemic antibiotic therapy regime includes tetracycline or erythromycin 250 milligrams orally 4 times a day for 3 to 4 weeks, or doxycycline 100 milligrams twice a day for 3 to 4 weeks constitute the traditional standard systemic therapy. So we can use either of them, tetra or erythromycin or doxycycline. Doxy is preferred these days. Azithromycin 20 milligrams per kg body weight up to a maximum of 1 gram as a single oral dose is effective as a 6 weeks of topical therapy, and so is presently considered the first choice. Azithromycin is supposed to be very effective, even as a single dose. It is not used in pregnancy and children below 6 years of age, so we have to be cautious not to use azithromycin in pregnancy and in children below 6 years. A combined topical and systemic therapy regime, it is preferred when the ocular infection is severe or when there is associated genital infection. It includes tetracycline or erythromycin eye ointment twice a day for 6 weeks, and azithromycin single dose or tetracycline or azithromycin, as I described earlier, can also be combined. So this approach is called the combined topical and systemic therapy approach, and this can be employed when there is a severe infection. Now, for the cicatricial trachoma, the disease now has healed up or it has become white, but cicatrization or the sequelae are still there. So, trachoma scarring measures include concretion should be removed with a hypodermic needle. Conjunctival xerosis should be treated by artificial tears, that is, lubricating drops. Trachoma inactive includes trichitis and cicatricial entropion, which requires appropriate treatment. Trichitis means effusion-directed cilia should be treated with a permanent lace removal measure such as electrolysis or cryolysis and radiofrequency ablation. Bilabial tarsal resection is a surgical procedure of choice for multiple misdirected laces. So bilabial tarsal resection may be required for certain cases. Cicatricial entropion should be corrected surgically. Now, CO stage, that is corneal opacification stage. Now, the treatment here is penetrating keratoplasty, which is indicated for significant corneal scarring. However, the outcome is less than optimum as these patients have extensive corneal vascularization, which is a risk factor. Keratoprosthesis may be indicated in bilateral blind cases with extensive corneal scarring and ocular surface problems. Fungal occlusion and the lateral tarsality can be done, which takes care of the coexistent ocular surface problems. It may be useful adjuncts for increasing the success of surgeries. So we understand that the penetrating keratoplasty or keratoprosthesis may be done, and fungal occlusion and lateral tarsality takes care of the coexisting ocular surface disorders. Prophylaxis of the trachoma infection and the blindness. So the WHO has given a safe strategy. So what is that? The WHO gets 2020 program, that is global elimination of trachoma by 2020, which has adopted the so-called safe strategy for the prophylaxis. And what does that mean? SAFE. S is for surgery, that is a tertiary level prevention. A is the antibiotic usage, that is secondary prevention. F is a facial hygiene, that is primary prevention. And E is the environmental changes, that is a primordial prevention. So all these factors, that is SAFE, should be taken into account when we handle or when we approach the trachoma infection. And that is what is the strategy known as safe strategy suggested by WHO. Environmental changes are important. Flies and the other fomites are the common cause of spread of the trachoma. So environmental sanitation, which constitutes the primary primordial prevention of trachoma. Recommended environmental sanitation measures includes provision of the water latrines and good water supply to reduce flies and improve the washing habits. Refuse dumps, spray to control flies, and health education to improve personal and environmental hygiene. Facial hygiene is a primary prevention measure. Frequent face wash with clean water to eliminate the potential infectious ocular secretions. Should be done. Avoidance of the common usage of towel, handkerchief, soma rods, etc. should be done. Very important facial hygienic measures to prevent the spread of the trachonitis infection. Antibiotics for the prevention against the trachoma, there is a second infection. In areas with more prevalence of the acute trachoma is seen, the recommendations are as follows. The areas having 10% or more prevalence of the acute trachoma should be targeted. How? Oral azithromycin, single dose of the 20 grams per kg up to 1 gram should be administered to all the community members because the entire community is at risk. 10% is a bit higher and alarming figure. So if that much is the prevalence of the active trachoma, the entire community should be covered by the oral azithromycin. Tetracycline eye ointment twice a day for 6 weeks is recommended for all pregnant women, children, 6 months, and those allergic to the electrolytes. So that is the approach of the antibiotics for prevention against trachoma. In areas with the prevalence between more than 5% but less than 10%, the targeted antibiotic therapy is recommended only on the family members and close contacts of the patient, not the entire population, but only the family members and close contacts of the patient. That should be covered. In area where the prevalence is less than 5%, the treatment of patient only is recommended. The surgery is the tertiary prevention. Surgery for devices and entropy on constitutes the tertiary prevention for the trachomatis scarring blindness. WHO recommends bilateral tarsal rotation surgery at community level for the affected person. So for trichitis at transmarginal rotation or tarsal rotation, bilateral tarsal rotation is the surgery of choice in these cases. So friends, that brings to the end of the trachoma. Now a word about the angular bacterial conjunctivitis. The angular bacterial conjunctivitis is also known as the Moraxilla axillary bacillus conjunctivitis or the vascular conjunctivitis. So, if you look at the etiology of this conjunctivitis, there are predisposing factors such as exposure to the dust, smoke, and chemical irritants. Local cause of irritation such as trichitis, concretions, foreign body, and seborrheic scales. Eye strain due to the refractive errors, phoria, or convergence insufficiency, abuse of the alcohol, insomnia, and metabolic disorders. If you look at the causative organism, it is the Moraxilla exempferi. This is the commonest causative organism, and the source of infection is usually the nasal cavity. Mode of infection is from nasal cavity to the eye is by the contaminated fingers on handkerchief. So that is how the disease spreads. Pathology of the Morax exempferi bacillus conjunctivitis. Causative organism, as I said, is the Morax exempferi bacillus and produces a proteolytic enzyme which acts by macerating the epithelium. Proteolytic enzyme collects at the angles by the action of the tears, angles of the eye, which will macerate the epithelium of the conjunctiva, lid margin, and the skin, the surrounding angle of the eye. This maceration is followed by vascular and cellular response in form of mild grade inflammation. So what you get as a pathological feature is the proteolytic enzyme which accumulates at the angles and which leads to the maceration. The clinical features include these symptoms: irritation, burning sensations, and feeling of discomfort in the eye. History of collection of the dirty white foamy discharge at the angle is quite characteristic. Redness in the angle of the eye. Signs include hyperemia of the bulbar conjunctiva near the canthite. That is why we call it angular conjunctivitis. Hyperemia of the lid margin near the angles. Excoriation of the skin around the angles. And foamy mucopollen discharge at the angles. It is usually present. So all these features are so characteristic that you cannot miss them. There are certain complications which include blepharitis and a shallow marginal catarrhal corneal ulceration. Treatment of diplobacilli or axon-filled bacillus conjunctivitis include the treatment of associated nasal infection and a good personal hygiene, which is the prophylactic measure that should be adopted in all the cases. The curative treatment consists of oxytetracycline 1% eye ointment 2 to 3 times a day for about 2 weeks, which will eradicate the infection. The zinc has a special role. The zinc lotion instilled in the daytime and the zinc oxide at bedtime inhibits the proteolytic ferments and thus helps in reducing the maceration. The zinc helps in reducing maceration by its special effect by inhibiting the proteolytic ferment and constitutes an important part of the treatment of the diplobacilli or Morax axon-filled bacillus conjunctivitis. Thank you.